And oh, question 2, we will start now. I'll start the timer. Okay, so that's about 2 minutes there. And so the answer to this question is A, category 1 cesarean section. And this is one that often gets a bit of discussion. So one of the things that you have to be able to identify from this question is that this is a lady who is not yet in labour. So we're looking here at an antenatal CTG that's been done on the induction ward in the hospital. And when we look at the findings within the CTG, we can see that there are no accelerations, which we will talk a little bit about later, but that's a kind of a bit of a warning sign. And also that there are decelerations in the absence of any uterine contractions. So this would be considered to be a pathological CTG, and the recommendation therefore would be for expedition of birth through a cesarean section. Okay, and then we'll move on then to question 3. Okay. So for this question, this is something that we might feel as obstetricians something maybe slightly less comfortable with. So this is a lady who's on the birth centre, midwife led for her intrapartum care. And the answer here is E, intermittent auscultation after a contraction for 60 seconds every 15 minutes. And we'll talk as we go through the kind of content of today's session a little bit about the recommendations on the birth unit. It's definitely worth us knowing those in terms of our clinical practice, but also because they form part of the NICE guideline, they're a very easy thing to write questions on in the exam. So it's definitely worth definitely worth learning about the kind of normal birth pathway as well. Okay, so looking then specifically at the NICE guideline, what I've done here, just to sort of go or give you a little warning, I suppose. I've read this guideline several times, obviously, and produced what I think are the kind of highlights of it. But it's by no means a substitution for you reading the guideline yourself. So it's still important to have a little read through. But what I've picked out are the things that I feel are the most easy things to write questions about, because obviously everybody will approach their revision in a different way. But certainly when I was revising for my exams, the way that I did it was read the guidelines and then think about what would be easy to write questions about and read those areas with particular detail to try and target my learning, because as I'm sure you're all aware, it's impossible to know everything about everything. So you've got to be a bit canny about it. So what the NICE guideline says is that all CTG or all fetal monitoring, so we're including in that intermittent auscultation, has to be interpreted within the wider clinical picture and the wider clinical context. And it also talks quite a lot about the importance of consent and discussion, and that it's an informed choice as to what type of fetal monitoring a person decides to have, if any. And that it's important that we discuss the kind of pros and cons and the indications for the recommendations that we're making when it comes to fetal monitoring. And it definitely shouldn't just be a kind of blanket, everybody gets slapped on a CTG. That the person and their family need to know why that's being recommended and what their options are, so that they can make an informed consent decision. It's also really important in and included within the NICE guideline is it talks about the acknowledgement of the risk of intervention when you put somebody onto CTG. So we know that the rates of instrumental birth and caesarean birth, of epidural, are all higher when somebody has CTG fetal monitoring over intermittent auscultation fetal monitoring. That's probably because it's put on in the presence of doctors and we like to find problems and fix them. So, a birthing person has to be aware that that is the case, so that they are making truly informed consent. It then goes on to talk a bit about intermittent auscultation, and it recommends that can be done using a pinard or a handheld Doppler. So both would be validated and equally as useful. That when the fetal heart is being recorded, that we should be palpating and recording the maternal heart rate at the same time, and that is obviously to avoid any confusion of misrepresenting the fetal heart rate with the maternal heart rate. That we should be recording the presence of accelerations and decelerations onto the partogram. And then it talks about the frequency and duration of intermittent auscultation. And in the first stage of labour, we should be listening in immediately after a contraction for at least 60 seconds every 15 minutes. And then when we get to the second stage of labour, it should be every 5 minutes after contractions for 60 seconds again. So it's relatively straightforward to remember, hopefully. 60 seconds for both, 15 minutes before we start pushing, and every 5 minutes once we start pushing. And then it talks a little bit about at what point escalation to consider CTG or obstetric input might be appropriate. And it says that if the fetal heart rate baseline rate has increased by 20 beats per minute, or a deceleration is heard, that we don't just bung somebody onto the CTG at that point. We increase to auscultate after the next 3 consents. And if we still have clinical concern because of what we're hearing with our intermittent auscultation, then we would recommend or advise a CTG and transfer to a consultant-led unit, whilst still acknowledging, as it said in the NICE guideline, that that is a consent process, and the woman and her family need to be involved in that discussion. It also goes on to clarify that if the CTG is normal at 20 minutes, then there is the option for a woman to be transferred back to having intermittent auscultation, whether that means being moved back to a birthing centre with midwives or intermittent auscultation on an obstetric-led birthing unit. So it then moves on to talk a little bit about continuous CTG fetal monitoring. And as I've said, it emphasises the importance of discussing the pros and cons. And it specifically lists that we need to indicate that it might restrict a person's mobility during labour, And also that a normal CTG we can find reassuring for fetal well-being, but that sometimes an abnormal CTG may not be a true sign of fetal compromise. And I'm sure all of you know from your clinical practice, the number of times that we have concerns about a CTG and we recommend a cesarean birth, and then the baby comes out screaming its head off with normal gases and we all look like Wallies. So it's important that people know that it's not an exact science, and that there is a certain false positive rate when it comes to using continuous CTG. So looking then at antenatal indications for continuous CTG monitoring, we can divide these into maternal or fetal. A lot of these will be common sense to people who are practicing on the labour ward. So maternal indications, a previous caesarean section or any other uterine scar. So that might include somebody who's had a myomectomy with a cavity breach, or somebody who's had a uterine rupture during maybe surgical management of miscarriage or surgical termination. Any person who has hypertensive disorder who's requiring medication. People who have had prolonged rupture of membranes of more than 24 hours and they're not in labour. Or if they have established within labour within that 24 hours, then they can have intermittent auscultation. Anybody who's having any kind of antepartum hemorrhage, where there are concerns of chorioamnionitis, and then women with type 1 or type 2 diabetes, and women with gestational diabetes who require medication. So not those who are non-medicated or managing just with diet modifications. Within the fetal antenatal indications, it would be babies in a non-cephalic presentation, and that should include the entire duration whilst the decision is being made about mode of delivery. So, if you have a lady with undiagnosed breech presentation who turns up in maternity triage, they should be on continuous CTG monitoring until they've decided and been counselled about their options for birth. Any baby that has a small gestational age or fetal growth restricted to under the 3rd centile. And then any baby under the 10th centile with abnormal Dopplers or oligohydramnios. So a baby that's from the 3rd to the 10th centile on a growth chart with normal Dopplers would be considered, according to the NICE guideline, to be constitutionally small, and they would be suitable for intermittent auscultation. Another antenatal fetal indication would be anybody where there's any evidence of placental insufficiency. So that might be a baby that's perhaps dropping centiles, maybe has gone from the 80th to the 50th centile, for example. Anybody who is extremely post-dates, so more than 42 weeks gestation at the onset of established labour. Women with anhydramnios, oligohydramnios, or polyhydramnios. And anybody who's had reduced fetal movements in the 24 hours before the onset of regular contractions should have be recommended continuous CTG monitoring during their labour. Then we can look at risk factors which might develop intrapartum. And these are a little bit more tricky to remember because there's some quite specific parameters. So I've tried to simplify them as much as possible. So this would include people who have prolonged contractions, specifically lasting more than 2 minutes per contraction, is what it states in the guideline, or women who have more than 5 contractions in 10 minutes. Where there's the presence of meconium, and it just states meconium, there's none of this thin meconium, thick meconium, it's just meconium. Maternal risk factors that have developed intrapartum, so that might be essentially evidence of sepsis, which might make you think of chorioamnionitis, or evidence of conditions that might affect placental function, which would be hypertensive disorders and preeclampsia. And there are these specific parameters listed within the guidelines. So a one-off pyrexia of 38 degrees, or 2 measurements taken 1 hour apart of greater than 37.5. 2 maternal heart rates of more than 120 beats per minute taken 30 minutes apart. Evidence of mild hypertension on 2 occasions, or evidence of severe hypertension on 1 occasion, and then a testing diagnostic of preeclampsia, so proteinuria and hypertension. Any patient where there is a suspicion of chorioamnionitis or sepsis, Anyone where there is abnormal pain that might make you think of abruption or other reasons for abnormal pain. Again, we've talked about APH, so newly diagnosed APH, and it specifically details as well newly blood-stained liquor not associated with vaginal examination. So again, a kind of a niche detail that it would be very easy to write an exam question about. People where there are confirmed delays in labour, so stalled progress in cervical dilatation. Anybody who's having regional anaesthesia in the form of an epidural or a remifentanil patient-controlled analgesia, and any labour that's being augmented with syntocinon. So all of those people should be considered for recommendation of continuous CTG. So the NICE guideline details particularly kind of strict standards for the CTG review. And it says that at every CTG review, which should be carried out hourly, we should be reviewing all previous traces and fetal heart auscultations as part of that hourly assessment. And that is so that we can make good comparisons, as we'll see later, with previous baseline rates and variability patterns, because that affects how we would interpret our most recent CTG. During that hourly assessment, we should also be palpating the maternal heart rate and documenting it to demonstrate that it is different to the fetal heart rate, so that we can be sure that we are monitoring mum and baby separately. And if for some reason we did have concerns, perhaps that we were not distinguishing between mum and baby properly, then it recommends offering ultrasound scan to better place the transducers, or to visually record the fetal heart rate, considering fetal scalp electrodes, using auscultation with a Pinard or Doppler to, again, locate the heart rate better and get a different type of recording whilst palpating the maternal pulse. And then using pulse oximeter and maternal heart rate tracing concomitantly at the same time, so that we can really accurately demonstrate that we're definitely measuring mum and baby separately. So this is a table that demonstrates all of the different parameters that should be looked at within a CTG, and what the sort of normal findings should be. And it within the NICE guideline, it characterizes the different parts of the CTG as either white, which would be considered as normal, amber, which is our sort of old suspicious, or red, which would be pathological. So I'm going to talk through them now, and then we'll go over the subsequent slides in a little bit more detail, and we'll try and come up with some cunning ways to memorize this list of seemingly impossible to remember numbers. So if we look at contractions, within the white, so the normal category, less than 5 contractions per 10 minutes would be normal. And the amber or suspicious category is, as we've said, greater than 5 contractions, or where the contractions are lasting for more than 2 minutes individually. With baseline rate, hopefully most of us know that the baseline rate should be between 110 and 160 beats per minute. And it specifically says as well that this needs to be stable. And so that's where the importance of being able to look back and review all of the other previous CTGs during each of those hourly reviews comes in, so that we can know, has there been an increase or decrease. And that's because when we move into the amber and red categories, as you can see, there are kind of marks that you would get within those categories because of changes in the baseline rate. So within the amber category, if we have an increase in the fetal heart rate of greater than 20 beats per minute in the first stage of labour, then that would be considered suspicious. We also would be looking for heart rates that are low, and it's the reason I've written normal underneath there, underneath the 100 to 109 beats per minute, is because the NICE guideline says that if we have a baseline rate of 100 to 109 beats per minute, in the absence of any other concerning amber features, it would be considered normal. And it only becomes significant if we have another amber feature, in which case it's enough to push us into being required to do something to confirm the well-being of the baby that we're monitoring. And then the other amber marking for baseline rate is if we're unable to determine a base rate. And that's because where we have a Wavering baseline, that sort of suggests that there might be poor myocardial oxygenation. So just thinking about the physiology of how baseline rate is established and maintained will help us to appreciate why it's important that we have a stable baseline that we're able to determine. And it may well be that we're unable to determine the baseline rate because we have a very active fetus that's having lots of accelerations or lots of decelerations. So having this particular feature in isolation doesn't necessarily mean that we need to deliver the baby, but it's a suspicious feature that we need to consider in the wider clinical context. If we move into the red category for baseline rates, we're looking, as it says here, at a heart rate of less than 100 beats per minute, or over 160 beats per minute, or an increase of 20 beats per minute in the second stage of labour. And we'll talk a little bit more about why that's important later on. If we look at variability, as we all know, a normal variability on a CTG is between 5 and 25 beats per minute. And within the amber range, we have either a low variability of less than 5 for 30 to 50 minutes, or a high variability of greater than 25 for less than 10 minutes. If those changes in variability exceed those time limits, then they become red flag characteristic findings on the CTG and would prompt a slightly different action. Within the red category, we're also looking for a sinusoidal pattern, and that's because of its association with fetal-maternal hemorrhage and fetal anemia. If we move into the decelerations column, within the normal white category, we could have a CTG that has no decelerations, early decelerations, or what they describe as variable decelerations, which is what a lot of us would consider to be the kind of baroreceptor decelerations, if that's the type of CTG interpretation that you're used to. So they have no concerning features. And concerning features is a particular phrase that's used within NICE guidelines, and we'll discuss what that actually means in terms of what the deceleration would look like in a few slides' time. If we move into the amber category, then we would be looking for variable decelerations which are potentially repetitive, which means occurring with greater than 50% of contractions, or concerning with concerning features, and that group should be lasting for less than 30 minutes, or concerning without repetition lasting for more than 30 minutes, or late decelerations. And late decelerations are significant regardless of the amount of time that they've been present for. Moving into the red category, we're looking then for variable decelerations which are repetitive and concerning for more than 30 minutes, late decelerations for more than 30 minutes, or those acute changes that suggest perhaps one of the non-reversible causes of fetal bradycardia. So an acute bradycardia or a deceleration lasting for more than 3 minutes. So there's quite a lot of information to remember in there, and quite a lot of kind of phrases that have a generic meaning, but within the NICE guideline mean something quite specific. So we're going to talk a little bit more about those things. But before we get there, as with the previous kind of FIGO classification and things that a lot of units would have used historically, we would be able to add up the features of the CTG that we have found to then classify our CTG as either normal, suspicious, or pathological. So a normal CTG constitutes all of the characteristics that we've assessed being white, and the recommendation then is that we just continue with our full assessment and comparing with previous CTGs every 60 minutes. If we have one amber finding, then we would consider that to be suspicious. If there are no other risk factors, then conservative measures are appropriate and recommended, such as altering maternal position, considering fluid if that's appropriate. If there are other risk factors present, then we would need to consider doing something to demonstrate or make the baby demonstrate to us, I suppose, that it is well and deserving of continuing in the labour process. So NICE stimulation. And if it's not possible to do that, perhaps because the cervix is not dilated enough, then we should have a consideration to expedite the birth as well. If there are 2 amber flag characteristics or 1 red flag, then that's considered a pathological CTG. We should exclude acute causes, and by that it means things like hypertensive crisis secondary to regional anaesthesia. We could consider conservative measures, so we could, for example, in that particular case, we could give IV fluids to try and restore normal tension, and we could reposition the mother, etc. But ultimately, we need really to be considering about expedition of birth at that stage. And the process or mode of birth would really be dependent on the stage of labour. It then goes on to mention specifically acute bradycardia of greater than 3 minutes. And a lot of you will know, I've heard the 3, 6, 9, 12 rule. So it talks a little bit about that. So excluding the non-reversible causes of acute bradycardia, which would include uterine rupture, cord prolapse, and placental abruption. And that we should be thinking about expediting the birth by 9 minutes of bradycardia, or earlier if there are significant risk factors. And it specifically talks in the guideline about making sure that we document the time of decision and the time of birth. And that is for governance and medico-legal reasons. If we've moved somebody to theatre at 9 minutes because we have a concern about an acute bradycardia, but the CTG recovers and we're able to be reassured about the fetal well-being, then we can reassess the decision to expedite the birth. We don't. There's no compulsion within the NICE guideline for that to happen, as long as the baby is well. Okay, so talking a little bit about decelerations now, and I apologise for my sketches, which I made on paint to try and sort of demonstrate what I mean. As we said, we can classify decelerations as early, variable, or late. They don't use the phrases typical and atypical, which I can't see how old some of the people on this call are, but it's something that typical and atypical are the phrases that we used to use a lot when I first started training. And you can see in the two images I've drawn, the top one would be your sort of baroreceptor deceleration, your variable deceleration. So there's the presence of shouldering, there's variability throughout the deceleration, even in the trough, and shouldering before and afterwards. And there's a kind of swift down, swift up tick, return to baseline with no rise in baseline after the deceleration. So that's a variable or what we used to call typical deceleration. NICE defines repetition or repetitive decelerations, as I've said, as those which are present with more than 50% of contractions. It also defines some shallow decelerations. And the definition of this is decelerations with of the whole CTG trace. And they are quite specific to look at, and I'm sure most of you have seen them on CTGs, and they would be a red flag characteristic within that table. NICE also describes what it considers to be concerning features, and they are basically all the features of a chemoreceptor deceleration, or what we would have called an atypical deceleration. So that they last longer than 60 seconds, that there's a loss of variability within the trough of the deceleration, there's a slow return to baseline or a failure to return to the original baseline rate, so we finish at a lower baseline rate, and loss of previously present shouldering. It then also within the guideline goes on to talk about some quite specific kind of exemptions or inclusion criteria, which can be hard to remember because, again, it's a big list of numbers. So I've tried to include some kind of anecdotal ways that I remembered or remember these things. So if we look at low variability features, if we have low reduced variability for less than 30 minutes, we've already said that this is a white kind of classified feature. So I think of that as like a quick power nap. You know, I've got half an hour, just put my head down quick, have a lovely nap, wake up feeling lovely and refreshed. The way that I remember that amber feature, this is a reduced variability of less than 5 beats per minute for 30 to 50 minutes. Think of your REM cycle, which is between 45 and 50 minutes for the average person. So it's like you've laid down for a quick nap, but you're actually quite tired, and you've managed to wake yourself up after one REM cycle, but you know, you don't always feel that great when you wake up, do you? Because you've sort of slept for a bit too long almost. And then if we look at the red category, this is a nap that's just gone on for far too long, and you know you're going to feel worse afterwards, even though you thought you were going to feel better when you laid down. So that's that reduced variability of less than 5 beats per minute for more than 50 minutes. So looking then at increased variability, and so I've got small children, so this is how I remembered these kind of parameters. So increased variability of greater than 25 beats per minute for 10 minutes falls in the amber category. And I remember that as my 3-year-old, if I go to the cafe and I give her a hot chocolate, she's going to be fairly hyperactive because she's not used to the sugar. And for about 10 minutes, yep, I can tolerate that hyperactivity. So we're going to stay in the cafe, and I'm not going to confiscate the hot chocolate just yet. But after 10 minutes, I'm probably going to be taking the hot chocolate away, and I'm going to be thinking about leaving the cafe because the other customers are going to start getting very annoyed at her screaming and squealing and running around the place. So within amber, we're sort of, giving that toddler, an evil, dirty look, calm down or else. But at red, at 10 minutes within that red category, we're thinking, okay, no, something's definitely not right here. We need to get rid of the sugar and go to the park, burn off some of that energy. There is also described within the NICE guideline this kind of characteristic of short bursts of increased variability, which may only last for a minute, 2 minutes, something like that. And then you get a more normal looking variability in between those episodes. And this, again, falls into that red category. So we need to be thinking here about the reason why this might be happening, so the sort of physiology behind it. And it's a demonstration of poor perfusion of the autonomic and nervous system. So we're thinking here that we've got poor neurological functional, poor neurological control. So I sort of imagined it a bit like epileptic seizures or preeclamptic seizures, that we're just losing control over and over and over again. And, eventually we're going to head into a period where we're not going to be recovering from that. So again, that's something that that we need to be aware of and intervening if we see on a CTG. When it comes to baseline rate, one of the things that's a little bit more difficult to remember is that the increase in baseline rate of 20 beats per minute is slightly differently categorized whether we're in the first stage or the second stage of labor. And so the way that I like to remember this is to think about people who are running marathons. So if the labor is a marathon, at the beginning of the marathon, I'm running, and my heart rate might increase by 20 beats per minute, but I'm able to manage, I'm able to tolerate that because I'm in labor and I'm, still got some reserves. I've got my gels to eat or whatever it is as I'm going around. But as I get to the end of the marathon, so now I'm starting to push in my labor, my energy reserves have already been used up. I'm already a bit exhausted, and now you're expecting me to run up a hill. What on earth's going on here? So that's why in the second stage of the labor, that increase of 20 beats per minute becomes a red flag rather than an amber flag. So it's just to do with the amount of reserve that a baby might have to tolerate the additional demand on their cardiovascular system. The other thing that it specifically mentions is to do with accelerations, and that accelerations indicate a well baby. But in labour, the absence of accelerations doesn't necessarily indicate acidosis or hypoxia. So antenatally, certainly, which is a little bit outside of the scope of this discussion, but antenatally, we should be expecting to see accelerations to confirm fetal well-being. But intrapartum, we may not see them, and that doesn't necessarily mean anything. So it's something to be interpreted within the wider clinical context and the rest of the CTG. Okay, so exceptions. So things that are slightly outside of the rules. If we have a CTG which demonstrates decelerations with no concerning features, and all the other parameters are within the white row of the table, then we should be encouraging mobilization and repositioning rather than jumping in and doing expedition of birth or anything else that we might be able to do to confirm fetal well-being. It specifically mentions that early decelerations are representative of head compression. So that's, again, something that would be very easy to write an exam question about. It talks about where there are decelerations for greater than 30 minutes with an increase in base rate or a reduction in variability, that those two things together should necessitate urgent obstetric review and putting in place some sort of conservative measures of to change the intrauterine environment for the baby so that it can demonstrate to us that it's well. And also reduction in variability for greater than 30 minutes with other risk factors, that should really, it sort of emphasizes, I suppose, the importance of interpreting within the wider clinical picture. And the way that I have tried to remember this as I've written here is, if I'm having my little power nap for 30 to 50 minutes, I've gone through my 1 REM cycle of sleep, I wake up, then that's fine. But if I've had a head injury, you don't really want me to sleep for prolonged periods of time, because how do we know it's not because I'm got cerebral edema or something. So just trying to think, that where there are other risk factors present, you want the baby to wake up and demonstrate that it's well within those 30 minutes. So it then goes on to talk a little bit about the underlying causes and conservative measures that we can do. And I think I've touched on a lot of this already. But as I said, if we have any evidence of hypotension, and that can have association with the prolonged bradycardias, then we should be thinking about changing the maternal position, avoiding supine position, and using IV fluids in combination to achieve normal tension. But the use of IV fluids outside of that context should be done very judiciously. And NICE doesn't really recommend the use of IV fluids for management of any other CTG change or any other causes of CTG changes. Where there is tachysystole in the presence of augmentation, that we should be stopping augmentation, so stopping syntocinon and administering terbutaline 0.25 intramuscularly. And then talking specifically about fetal scalp stimulation, if we are required to do scalp stimulation, that if we don't see any evidence of response from the fetus, so we don't see an acceleration in response to that is very suggestive of fetal compromise, and we need to take that very seriously when we're considering what our action might be in response to the CTG changes. It also talks a little bit about the use of oxygen, and that should only really be used if the mother is hypoxic or during the pre-oxygenation process for general anaesthesia, where that's being used for cesarean birth because of the association with fetal harm. Okay, so that is all I wanted to talk through from the NICE guideline. They are my sort of highlights and top tips. So what I've got now are, I think, 7 more questions that we can go through, and yeah, I will just crack on with them. I'll start my timer again, and we'll give you another sort of 1.5 to 2 minutes per question. And again, after each slide, the answer is there. So, okay, let's go. Okay, so that is coming up to 2 minutes. So the answer is G, intermittent auscultation after the next 3 contractions for 60 seconds. So this is relating to the fact that the midwife has heard a deceleration, a possible deceleration following uterine contraction. So as we were saying, rather than just then transferring that patient to the consultant-led unit and commencing a CTG, the recommendation would be for auscultation after the next 3 contractions to confirm that there is a concern, and then commencing a CTG at that point if there was. Okay, question 5. Okay, so the answer to question 5 is C, commence intermittent auscultation. So she's attended the labour ward, she's in labour. She does have gestational diabetes, but she's not taking any medication for it. So she falls within the group of women who would be able to be offered intermittent auscultation for fetal monitoring. Question 6. Okay. So the answer for question 6 is B, commence intelligent intermittent auscultation for 60 seconds every 15 minutes. So in this question, we've got a lady with a mildly elevated BMI, but no past medical history, baby's well grown, maternal obs all fine, baby's in a good lie, she's in labour, pinky stained liquor and a small amount of mucus and fresh red blood on the glove. But the importance is that that bleeding and pinky liquor is within the context of a vaginal examination. So it would be considered to be a normal finding. So we can recommend her for intermittent auscultation rather than CTG. Question 7. Okay, so the answer for question 7 is M. This is a suspicious CTG, and we would recommend IV fluids and antibiotics. So if we look through the clinical stem, we've got a preterm lady with what sounds like a urinary tract infection and reduced fetal movements. So, we've got to interpret our CTG within the context of that clinical picture. She's a little bit tachycardic with heart rate of 119 beats per minute, and the baby has an increase in baseline rate, but of less than 20 beats per minute. There aren't any accelerations. Again, we're not in labour, so we need to be suspicious of that. And there aren't any decelerations, and the variability is mildly reduced. So in the first instance, because we have suspicions about the cause of this, which may be reversible, we could recommend IV fluids and antibiotics. If IV fluids and antibiotics, if M wasn't an option, then L would probably be the next best answer, because we're having to interpret that CTG within the antenatal context, where it would be considered to be abnormal because of the absence of accelerations and the increase in baseline rate and reduction in variability. Right. Okay, so the answer to question 8 is B. Commence intelligent intermittent auscultation for 60 seconds every 15 minutes. The reason for that is that we have a small for gestational age baby, but that has been consistently measuring on the 7th centile with normal umbilical artery Dopplers and amniotic fluid volume. So we would consider this to be a constitutionally small baby, and therefore in labour it would be suitable that she was recommended for intermittent auscultation rather than CTG. Question 9. Okay, the answer to question 9 is A, commence CTG. And this is because we've got evidence of placental insufficiency. So we've got a baby that's dropping their estimated weight centiles on the growth chart. And so that would be an indication then for CTG rather than IIA to be recommended. Okay, we're nearly at the end, folks. Well done for sticking with me. We have question 10. Okay, and so the answer to question 10 is H. Offer instrumental or cesarean section to expedite the birth. So if we look back at the CTG, we can see that she's got an increase in her baseline rate of more than 20 beats per minute for 30 minutes. We're in the second stage now because we're pushing. So we're at the end of our marathon running up that hill. So we're now in the red zone. So that in itself is enough for us to recommend expedition of the birth. If we look a little bit further down, decelerations, variable with no concerning features and non-repetitive, would fall within that amber category. And I should have said earlier on that obviously a red feature trumps an amber feature. So, we always act on the most severely classified portion of the CTG. Okay, so that is all that I had to say. Thank you very much for joining me this evening. Saranya, I don't know if you want to talk. I will stop sharing my screen.
Thank you so much, Dr. Lee, for your time. That was such an extensive presentation. And thank you. Really appreciate your time and effort. Any questions, anyone? Do we conclude the session? All right. Thank you all for attending and thank you all for joining us. Thank you so much again, Dr. Lee.
Thank you. Thanks, everybody. Good luck.
Thank you. Bye.
Thank you so much.
You're very welcome. Good luck. Good luck, everybody. I hope it goes well.
Thank you. Thank you.
Thanks.
Thanks.
Bye.